Today, we're going to go over the biopsychosocial model of mental health treatment and kind of parse out why this should be the model that is adopted by the US and how some of the other global powers have adopted it and how it compares to the other models that are out there. So this was a model that was first proposed by George Engel in 1977. So it's a fairly new model when it comes to mental health care. And the idea is that it looks at the complexity of these mental health disorders from a biological standpoint, which we've covered, but also the psychological and the social component of it. So it no longer looks at mental health disorders as a disruption of purely the biology and focuses more on the other outcomes that matter, and we'll dive into that a little bit more, and we'll also talk about why this biological component took shape and why it became so successful, and still is prevalent today within the research and within the care units. So the idea is that we're focusing on a model as a person as a whole, right? And the person is not someone that suffers in isolation of certain organ parts, but rather as the mind, body, and the environment. And we look at this idea as these three domains, and how can we put those together in a comprehensive way that makes it a successful healthcare program for people that do suffer from mental health disorders. And the over the past decades, this model, this biopsychosocial model, or BPS model for short, has been a theory that's been widely accepted and used as a guiding framework and understanding of mental health disorders. And every major health condition can be analyzed through this lens. So depression might involve a genetic vulnerability or a neurotransmitter imbalance, which those are kind of like the biological sides of things. So those things do matter, and pharmacology is important, and for some people and for a lot of people. And but then you have the psychological component of depression, which is negative thought patterns, this rumination, this worry, or trauma. And then you have the social isolation component, right? Or poverty, like that. Those are the social dynamics of it. So that's kind of the lens we're starting to look at, where a purely like biomedical, biological approach is going to be thinking more along the lines of medication only, SSRIs. How can we improve that dynamic and then move on? Or the psychological component, which is just therapy only, either some kind of cognitive behavioral therapy or psychoanalytic therapy. And by focusing on the singularity of those things instead of the whole, we start to miss these critical pieces. And so we're thinking about like comprehensive care, trying to combine interventions of medication, psychotherapy, and social support. And then what programs can we establish that allows us to do that in the US? Um, so some of the things to think about in terms of biological factors is this physiological or genetic underpinnings of mental health, right? That's the biological component of it. So the heritable risk factors, the brain structures and neurotransmitters that go into these mental health disorders, the hormones, the physical health conditions, and other bodily processes. So an overactivity of the amygdala might heighten the anxiety response, or a polymorphism in serotonin transport genes might predispose someone to depression. And many serious mental health illnesses have demonstrable biological components to them. Through neural circuit dysfunction, dysregulation, or neurotransmitter imbalances. And these biological components are extremely powerful and worth looking into. So this is not to necessarily knock that component of things, but we also want to figure out like why the shift has been from purely focusing on the biological side. And I think with the advent of neuroscience, that allows us to dive deeper into the brain and come up with some ideas of what we can build and how we can facilitate that. And some of the reasons why it is so powerful is a lot of times it can, and it's been proven to save people's lives and give people opportunities to overcome some of these mental health disorders. So it's not necessarily a negative thing, but it does come with side effects. So we have to keep those things in mind. So biological interventions, those are treatments that act on the body's physical systems or chemistry in mental health care. The most common being the pharmacological side of things with antidepressants, medications like SSRIs, to adjust the serotonin that's in the brain, or the epinephrine that's in the brain. There's also mood stabilizers like lithium for bipolar disorders to regulate neural excitability. And then there's the antipsychotic drugs for schizophrenia and psychotic disorders targeting dopamine pathways, and the anxiolytic drugs to help with anxiety and panic attacks. So some other biological treatments that have been shown to be very effective is the electric convulsive therapy for severe depression, and transmagnetic stimulation. So transcranial magnetic stimulation, repetitive TMS for depression, has emerged as a very viable tool, FDA approved, and that allows us to help people without going into these neurotransmitter pathways. And the reason why transcranial magnetic stimulation works, and one of the reasons why it tends to push away from this idea that neurotransmitters are the key driver, and these these pharmacological interventions that target neurotransmitters that come with these negative side effects aren't necessarily something that has to be done. With the transcranial magnetic stimulation, we see that we can improve depression in people, and it has nothing to do with serotonin, and it typically has to do with when you see it being used, it's used in most of the time it's used on the left dorsolateral prefrontal cortex, and they do these interventions of anywhere between 4,000 5,000 stimulations over a 5-day period, and it's pretty aggressive, and that's been shown to have like 80 to 85% rate of reducing depression. And the reason is because in that left hemisphere, that's very much the excitability hemisphere. It's more of a positive affect hemisphere, not excitability, but positive affect. Whereas the right hemisphere is more negative affect. So you can imagine people with depression, that positive affect tends to get blunted. And what the transcranial magnetic stimulus does is it helps to excite those areas again and make it more of a tangible thing to get towards that positive affect without actually inducing a lot of neurotransmitters. So the idea is that there's all these biological components, and some other interventions we could think about is adequate sleep, nutrition, exercise. Those are things that can help from a biological standpoint. So, and then we get into this idea of what are some of the psychological treatments? What are some of the psychological interventions? And the reason we're covering it this way is because it's going to allow us to understand what the research shows when they do these combinations of pharmacological with cognitive behavioral therapy, or exercise with cognitive behavioral therapy, compared to one or the other by themselves, and why there is such an improvement. So the biopsychosocial model, it does caution that biological treatment alone may not lead to full recovery, especially if psychological or social drivers of the illness remain undressed, right? So think of it in terms of we can give somebody these pharmacological pills, these interventions, and that can help with the plasticity in the brain and create these new neurotransmitters to be readily accessible within the brain. But if the environment that the person lives in is what's causing the stress, and we're not able to take them out of that environment, then those pills are not going to do anything for that stressful environment that's creating the problem in the first place. Or anytime they come up with some type of negative stimulus, because they haven't gone to therapy, they don't have the tools to overcome them. And that's why we see a lot of times with these purely pharmacological interventions that there's a high relapse rate, due to one, that the about 50% of people do not take the medication they're prescribed, but also because they're not able to have the tools, or they're not able to get out of the environment. That's the thing that's causing the mental health disorder. It's not just this dysregulation. So some of the psychological interventions and factors, right, that encompasses the internal process of the mind that influences the mental health of the individuals. And these include an individual's thoughts, emotions, behaviors, personality traits, coping skills, belief, past experiences, such as trauma or adverse childhood events. Um, One thing to think of is like persistent negative thinking patterns or maladaptive beliefs, like I'm worthless, or catastrophizing thinking, constantly thinking that the worst is going to come, no matter what the situation is, no matter how good things are coming. You know that it's going to blow up. There's going to be something negative, and that's these thought patterns. My advisor, Dr. Grant, he works a lot in looking at the role of anxiety and negative thoughts and these ruminative patterns, and how they correlate to different areas of the brain, but through EEG, but also how they mediate each other and how they interact with each other. So he does really good research on that. And what we find is that these things contribute to depression, and these thought patterns aren't necessarily something that we can fix through pharmacological interventions only. We need to give people the tools through talk therapy, dialectical behavior therapy, cognitive behavioral therapy, so that they can overcome it. But one of the downsides of that is that you're trying to give somebody these tools to do the work, and it is work they have to be able to put in. Just like going to the gym, you go to the gym 20-30 minutes a day, and you do that your entire life, and then you take 6 months off, you'll see a deterioration in the muscle and the strength that you put on, or your aerobic fitness. It's the same thing with these behavioral tools that they are taught through therapy. Like, you have to train them often, and trying to get somebody who's depressed or anxious these tools to train is very difficult. So you can see why, if we add the pharmacological component to it, that's going to allow them to improve their mood, and then that may give them the energy to do the cognitive behavioral therapy interventions that we're proposing that they do. So you can see the balance and the interaction and the interwovenness that can be very successful in this biopsychosocial model. So also thinking about the psychological component, right? They have a history of trauma, can induce psychological conditions like PTSD, or influence how someone handles stress. Psychological factors um, also cover learned behaviors and conditioned responses. So like avoidance behaviors, or phobias. That's not something that we can overcome through pharmaceuticals. We have to do the interventions to improve that fear response through the inoculation of continuing to expose them to small intricacies of the fear. And that allows them to improve over time. And we can see why that happens due to a blunting of the amygdala response. And then some of the talk therapies that they have going on is cognitive behavioral therapy, and that helps patients identify and reframe negative thought patterns. I use this a lot in the research that I do, as far as like cognitive reappraisal and reframing negative thought patterns. And then those things can gradually change unhelpful behaviors over time. But it is something that they have to practice. It's a daily, almost like a daily meditative practice that they have to work on. They have a lot of worksheets, and they get the job done, but you have to make sure that you're able to put in the work. So it's effective. It's been shown to be effective for depression, anxiety disorders, PTSD. Then there's dialectical behavior therapy. It's a form of cognitive behavioral therapy. It's more of a talk therapy, hence the phrase dialectic. And this is useful for borderline personality disorders, focusing on emotion regulation and distress tolerance. And then there's the psychoanalytic therapy that was famously coined by Freud and Carl Jung. And this explores this unconscious conflict and past experience that may be contributing to the current problem. So you're able to dive deeper into the unconscious, and what could be causing that through childhood trauma or any other instances of a type of trauma. And then there are these trauma focused therapies such as eye movement desensitization and reprocessing, which has been shown to be effective, even though we are not sure why it's effective, but it has been shown to be effective. But there's also trauma focused CBT as well. So CBT has very specific areas that it focuses on, addressing traumatic memories and their psychological impact. And that's why we see things like the psychedelics being such a useful tool for a lot of people when it comes to overcoming PTSD. Something like MDMA or ecstasy is one of those things that, when used with therapy, allows you to explore those traumatic experiences in a heightened state of love and arousal. So it makes it a safe place for you to do that. And they do that with therapists. So they're able to take them on this journey to overcome this traumatic experience and create a new valence for it, and also give them a sense of control over it. So even within those therapeutic settings, we see that there is a drug component with an intervention component, and that seems to be far more effective for people that suffer from PTSD than some of these other things. And hopefully, through the process of continuing to do the research, it'll get FDA approved, and then we'll be able to do even more research and get it out to more people. Um, And then there's behavioral therapies like exposure therapy that we just talked about for phobias or obsessive compulsive disorder. And that's gradually confronting feared stimuli to reduce anxiety, or behavioral activation for depression, scheduling meaningful activities to combat withdrawal. And then there's family or couples therapy that helps address an interpersonal dynamics that affect the individual's mental health. And um, some other interventions that have been shown to be effective in the psychological components, like the psychoeducation idea. And that's one of the reasons that I wanted to do this podcast, is that the more education you have, the more you're able to condition to a fault, like you're able to foster an understanding and have better coping strategies. And then there's stress management techniques like meditation, mindfulness, relaxation training, and then social skills, problem solving skills training, and then peer support or counseling, right? The aim is to help the individual develop healthier thought patterns, emotional responses, and behaviors to negative stimuli or even positive stimuli. In many cases, psychological interventions have been shown to significantly improve symptoms and functions. Cognitive and family therapists in schizophrenia can reduce relapse rates when combined with medication. In depression and anxiety, psychotherapy can be as effective as medication, and a combination often works best. And then getting into like the social environmental factors for this component, and then what do those interventions look like? So the social factors, they're cover a broad context in which individuals' lives and external triggers or supports that affect mental health. The categories are relationship based, so family dynamics, marital status, friendships, social support network, community, cultural influences, education, employment status, economic stability, environmental stressors, resources, environmental resources, and the key social determinants like poverty, unemployment, lack of housing, discrimination, trauma, violence, exposure are well known to increase risk for mental health problems. Something we talked about in previous episodes is this idea, and we talked about this with Dr. Adshead as well, is that there's all of these little components that add up. And if we're not able to tackle them one by one and combine them together, then the person's never fully going to get as healthy as they can be. So we know that in utero, babies that have stressed mothers due to low socioeconomic status has a heightened response to fear and negative stimuli, because their amygdala comes out when they're born, their amygdala is enlarged and their prefrontal cortex is smaller, and that transcends throughout their entire life. And they've done really good research to showcase that. So we do know that the social component plays a huge factor in mental health disorders, and some of the interventions that they do kind of translate into the psychological component, but they, as you'll see that there's a tangible difference to them. Family therapy and psychoeducation, which we kind of touched on. This is the idea that we bring the entire family in the treatment, and we're educating them about the illness, and improving family communication has been shown to reduce relapse in disorders like schizophrenia and bipolar disorder. You can imagine, by having this education system put in place, that the families can see the signs and symptoms happening, and they can understand it so that they can combat it before it actually gets magnified into a full-on manic state, or something along those lines, right? So, and then there could be that miscommunication of like, hey, you don't understand what I'm going through, because you've never gone through this, so therefore how can you help me work through this problem? So by having that education can be very powerful. There's peer support groups such as PTSD groups, 12-step support groups for substance abuse. And this provides support, reduces isolation, and helps people learn coping strategies from their peers that have that lived and shared experience. Supported employment and education programs that help those with serious mental illnesses find and maintain meaningful work or continue schooling. Evidence shows that supported employment, such as individual placement or support models, can dramatically improve vocational outcomes for people with conditions like schizophrenia, which in turn improves self-esteem and social integration into that community. And then housing and community support, things like assertive community treatment teams, actively help individuals live in the community instead of hospitals or jails. The social component, as you can see, it's like it provides this sense of hope that, hey, there is something out there. There are people that care about me, but also there's these things put in place that if I do get this under control, I have options to live a more fulfilling and meaningful life. And what they found within the research with these assertive community treatment teams, that reduces homelessness in the populations that it works in by up to 37%, and is more satisfactory to patients than the standard care that they've normally got. And then there's social skills and rehabilitation, and that can help those with schizophrenia improve that interpersonal functioning. And psychological and psychiatric rehabilitation programs often encompasses vocational training. So they're teaching them a craft, they're teaching them a job, life skills, coaching, recreational activities, right? So they're around other people, they're having fun, they're engaging in exercise. And then you also address the social determinants, right? That might include like assistant patients and accessing financial benefits, legal assistance, right? We're giving them options, we're giving them hope, we're giving them opportunities to feel like they're contributing to the community. And we're also giving them the opportunities to not feel lonely or isolated. And the idea is it recognizes the environment around the person, and leveraging the community resources, which is vital as a direct clinical treatment. For example, veterans with PTSD, not only involved in therapy and medication, but also involved in community outreach work, and stable housing is something that they provide within certain veteran communities. And those components facilitate greater recovery, as you can imagine. And the World Health Organization has stressed poverty significantly increases the risk of developing mental health disorders, and mental health services must adopt strategies that tackle social determinants, not just provide medication. Right? We want to make sure that we're able to give these people hope and opportunities to contribute to their community and feel like they have a place. So how does that encompass everything? How can we look at that from a biopsychosocial model? One of the things that we can think about is loneliness and these somatic symptom disorders. So there's a lot of research going on right now about psychosomatic disorders, which is this idea, this prevalence of the psychological component to create somatic disorder. So think of like hypochondriacs, and we've seen this throughout the research that's been magnified. People are creating these psychosomatic epileptic disorders, and when they compare them with people that have epilepsy, they can see that the seizures are in different spots and in different areas. So they're able to distinguish between epileptic seizures versus these psychosomatic ones. And this is this idea that we're creating these disorders within ourselves. So we're going to look at loneliness. We're going to look at psychos or somatic symptom disorders, SSDs for short. Loneliness is this distress and feeling associated with a discrepancy between a person's desired and actual levels of social relations. So you see that social component coming in there, and it's the subjective experience of a quantitative or qualitative deficiency in one's social relationships. Previous studies have revealed that loneliness is relatively common, with between 10 to 44% of the general population in developed countries report some degree of loneliness, and it can trigger an attention bias towards social threat that causes a self-defeating loop of loneliness. So you have that negative feedback loop of loneliness, and it's associated with negative effects such as feeling fear and sadness, and that manifests itself into anxiety and depression. So that's a social component that's manifesting itself into a depressive mental health disorder. And then you have the SSD component. And the criteria for that is one or more somatic symptoms that are distressing or disturb daily life, one or more excessive thoughts, feelings, or behaviors related to somatic symptoms that manifest themselves, for example, in disproportionate catastrophizing and high levels of anxiety. And then the third criteria is the persistent experience of somatic symptoms that last for at least 6 months. They're associated with higher levels of loneliness and feelings of social rejection and invalidation. And a nice study done by Hutton et al. In 2021, they took 187 people, 63% were females, and it was 75 patients diagnosed with somatic symptom disorder and 112 healthy controls. And what they found were higher levels of loneliness were associated with more anxiety and depressive symptoms and somatic symptoms. And furthermore, the results showed that loneliness is associated with a higher likelihood of being diagnosed with a somatic symptom disorder. And they also found, interestingly enough, that higher educational attainment was associated with lower levels of anxiety and SSD symptoms, and a lower likelihood of being diagnosed with with somatic symptom disorder, consistent with the current body of literature. And they've also shown that lower levels of education might cause health issues through increased stress levels associated with lower socioeconomic status. So as you can see, this component doesn't allow you to have a pharmacological intervention that can suit that. Even though these people are coming to their doctors with depression and anxiety, if you just look at that, then you'll prescribe them medication because we want them to recover as fast as possible. But it's that social interaction component that's causing these issues, along with not having the tools to overcome that stress and those loneliness and that type of feeling of depression. So what they found also within this study is that through less effective coping strategies and health behavior or cognitive and information differences associated with different education levels, that people are more susceptible to loneliness and these somatic disorders. And they found that being employed was associated with lower levels of anxiety and depression and somatic symptoms as well, and a lower likelihood of being diagnosed with the disorders. And the health benefits of employment have been explained through like economic resources, social factors such as interactions with others, social status, and purpose and achievement. The things that we want to facilitate for these people through that social component, which is one of the things why I'm harping on that, is that's one of the things that gets neglected the most, right? But with loneliness, there's a biological component as well, right? There's a neurobiological mechanisms at play that we can start to look at and start to access through maybe some of those biological interventions. So when people experience loneliness, the brain activates systems related to stress. Chronic loneliness can lead to elevated cortisol levels, and that's the body's primary stress hormone. And then over time, that can start to dysregulate HPA axis. That can lead to cardiovascular disease, hypertension. It also blunts the reward system. It interferes with the ventral striatum and the dopamine pathways. And this diminished response can make the prospect of social interactions less appealing and harder to pursue. You can imagine that people that suffer from this, they have a hard time seeking social interaction as a reward because that dopamine system is blunted. And then there's also an inflammatory response. IL-6, TNF alpha, those things have been highly correlated with depression and anxiety. And loneliness is one of those things that's been linked to low grade systemic inflammation. And that can evolve into a response to social disconnection, and that can serve as a signal to the body to protect itself from potential dangers. And the brain areas involved in this component are very much brain areas that we talked about in other episodes. And it's been shown to impact regions involved in emotion regulation and self reflection, such as the anterior cingulate cortex and prefrontal cortex. So, exercise is one of those biological interventions that improves both those areas. So, that could be a way to overcome some of this loneliness. And then you could put them in a group setting, and that can bring that social interaction component, and it also creates self-efficacy, self-mastery. So that could be one of the biological interventions that we can look at along with the social one to combat the loneliness. And then it also affects the default mode network, which is active when people are not focused on external tasks. So think about meditation and those intrusive thoughts that come into your mind while you're trying to not have thoughts come into your mind. That's a default mode network at play, and it's thought to be involved in social cognition, and hyperactivity in lonely individuals could suggest that they are preoccupied with negative thoughts about their social situation. And then the social component of it. So we talked, that was just the biological. Now we have the social, and social isolation refers to the actual physical absence of social interactions. But relationships or loneliness is a subjective experience. So an example would be a person may be surrounded by others, but still feel lonely if they perceive a lack of meaningful or satisfying social connections. And then conversely, someone who's physically isolated but content with their solitude may not feel lonely at all. So the key to understanding loneliness is the quality of the relationships that the person has. The social pain hypothesis is an interesting one. It suggests that the brain processes um, affect physical pain engage in the same processes that affect social pain. So, like the anterior cingulate cortex and the insula, which are activated during physical injuries, shares a neural process potentially and indicates that emotional or social pain can feel just as real as actual physical pain, reinforcing the body's urgency to seek social connection. And then there's positive social interactions, stimulate the brain's reward pathways, which promotes feelings of happiness and contentment. And when it comes to like the interaction of these two, we have this feedback loop. The more biological distress an individual feels, the less likely they are to engage in positive social interaction. And that leads to this vicious negative feedback loop, which perpetuates loneliness, both psychological and physiological symptoms, making it increasingly difficult to escape the feeling of isolation. And then the chronicity of loneliness is where the negative effects of the biological response to loneliness become most pronounced. Over time, social withdrawal combined with ongoing stress. And so you can see why we need this biological, psychological, and social model to help improve those things. Because if we just focused on the biological, which is what most of the research does, we're going to be missing a ton of things that can help these people overcome some of these disorders without just focusing on the medication treatment alone. Um, So some of the research showing that combined treatment versus medication or therapy alone, there's a lot out there. Numerous studies on in depression, anxiety show that blending pharmacotherapy and psychotherapy leads to better symptom reduction and lower relapse than either alone. So patients with major depression who receive both an antidepressant and some type of psychotherapy often have higher response and remission rates, especially in moderate to severe depression. Those compared to those receiving just one of those modalities. Schizophrenia, we see the same thing. Targeting these family interventions reduce 1 year relapse rates by roughly 45 to 65% compared to treatment as usual. So bringing in that family psychoeducation component of social interaction and the psychological has been shown to have tremendous effects on schizophrenia and bipolar disorder. Effective management of that requires mood stabilizers, but research shows added benefits from psychosocial interventions. So again, the psychosocial education component for patients and families has been associated with longer periods of stability. And that could be due to the fact that maybe the patient know that the family has a better understanding. So therefore, they don't feel like they have to explore this like desire to fall into these manic or highly depressive states. They have people they can talk to. They have people that can understand them. And it's been shown to have fewer relapses and better adherence as well. And then PTSD, often a combination of trauma focused psychotherapy, such as prolonged exposure or cognitive processing therapy. And then, when needed, medications like SSRIs can help, or prazosin can help for nightmares. While some patients improve with therapy alone, many benefit most from the combination. And community support, veterans groups for trauma survivors, and that can help with enhance further resilience. And then, especially in terms of co um, these co-symptoms of the mental health disorders, thinking about substance abuse along with mental health disorders, there's really strong research showing integrated treatment to be more impactful and helpful. And one of the things that they do for a successful biopsychosocial model is they use this collaborative care model. And what that is that places a behavioral health care manager and consultant psychiatrist into the primary care setting to work alongside the primary doctor, effectively like addressing all three sides, right? The biological medication through the psychiatrist, um, and then the psychological brief counseling and the social needs care managers. What we see within the way the healthcare system is set up now is that typically psychiatrists, they get insurance based off of they have more likelihood to get insurance covered for 15-minute interactions than 50-minute sessions. So they're not only are they getting pushed, incentivized to have these 15-minute sessions. But there's also this component of if the psychiatrist is the one prescribing the medication, there's a lot of times that the therapist, the psychologist, is separate from the psychiatrist because the psychiatrist is pushing these 15-minute intervention sessions. And just imagine that you have 15 minutes to diagnose someone accurately and give them medication, and then they go home and then they're given a therapist, and that therapist works with them, right? And then you would expect the communication between the therapist and the psychiatrist to be fluid and consistent, but tends to not happen that way. It tends to be very disconnected. So we have two different people trying to work on one person, and the collaboration effort is not there because they're in separate vicinities and they're incentivized differently. So this collaborative care model has been tested over and over again, and yet it's still not 100% adopted, which is very frustrating. But they did a systematic review of 16 studies from 2008 to 2023, And they concluded within this review that the collaborative care led to statistically significant improvements in depression and anxiety symptoms in 12 of those 16 studies, and improved treatment access, and it was cost effective. One of the things that gets thrown out there is these collaborative care models are going to be more costly for the patients. But what they found within the research is that it's just as cost effective. And then the University of Washington, they did this impact trial study, and they showed that depressed older adults in collaborative care had much higher recovery rates than those in usual care. And these benefits persisted over years. So, in contrast to this biomedical only approach, where it just relies on medication adjustments or hospitalizations, and then you have the psychological only approach, which engages some in therapy. They fail to address this chemical response, the social, like they all have these shortcomings. And one of the reasons that they have these shortcomings is that's because that's the way the education system is built. If you go into psychiatry as an MD, you're going to be focused more on the medicine side of things. And then if you go into psychology as a PhD, you're going to be more focused on the therapy. And they don't have a lot of these collaborations in terms of education. Um, and they also don't talk about nutrition. They don't talk about exercise. So you don't get these models built in place through the education system. So that would be one of the biggest proponents of trying to get this model put into U.S. mental health care, is to have a more academic, rigorous approach to include in all these in some capacity. You want a psychologist to have a understanding of medication and what that does and what are the outcomes. And you also want a psychiatrist to have an understanding of the psychological side of things and what that does. So we have broad acceptance of the psychosocial model as a theory, but the US healthcare system has been struggling to fully implement it. Many clinics and programs still default to a predominantly biomedical one, again, because that's what they're incentivized to do. And some of the reasons why these things have not taken forefront, again, is because in 1980, advances in pharmacology, psychopharmacology, and neuroscience, this revolution led to huge investments in drug development and in brain research. And when people make these investments, they want a return on their investments. And although it's been very impactful and there's been a lot of meaningful research done, it's still the way that people get funded. And we know that in academia, funding is what keeps people continuing to get their jobs. And so we need to focus those funds on other attributes, right? And it's tough because I heard the other day that in the NIH for nutrition, they allocate about $1.2 million for nutrition research, which is not a lot. But one year they got it bumped up to like 112 million through people going in and talking about how nutrition is something that we need to study more. It needs to be valuable. And what happened was that the food lobbyists that pay for a lot of these interventions kind of hinted at this idea with NIH that like, hey, like probably not going to get funding to do research on nutrition, so it got bumped back down, right? So where this money is being allocated, who's given the money, who has the power, what are we focusing on as a academic, educational, and science-based is going to be something that needs to be shifted. And I think people are doing really good research to show that it does need to be shifted. Again, reimbursement and financial incentives. They have the U.S. through how healthcare is paid. It reimburses short, high volume medical visits and procedures over time intensive psychotherapy. So psychiatrists can be reimbursed for 15-minute med checks more easily than the 50-minute therapy sessions. And until recently, primary care physicians were not reimbursed for collaborative care or care coordination activities. So psychosocial interventions like therapy have no pharmaceutical company to champion for them because there's no patents to be sold. which means there's less systemic push to disseminate them. Um, as one policy paper points out, unlike new medications where the marketing of new practices is supported by patents, psychosocial treatments are not patented and therefore lack the economic incentives to promote them widely. So this leads to fewer clinicians being exposed or trained in the latest therapy techniques, because that's not what's incentivized, and consumers being less aware of non-drug options. And then there's just this fragmentation of services. The US lacks a unified national health system and mental health care, and it's often separated from general medical care. So again, we have this separation of, instead of this collaboration, and that the collaboration has been shown to be significantly more effective. And then there's the time and workload constraints. Thinking about the primary care doctors who handle the bulk of mental health prescribing in the U.S. Often only have 15 minutes per patient due to the enormous productivity pressures that they face. So the default is to get these quick fixes in, rather than delve into what could be going on, right? So we're over prescribing people these pharmaceutical interventions when in reality it could be the social component, it could be the psychological, it could be all three, right? But instead, we only have 15 minutes to just push it out, push it out, push it out, and that's been very, very detrimental to the mental health component that's going on right now. And then again, there's just inertia from institutional and culture. Everything's been pushed to this biomedical, and it's been marketed and it's been successful and it does help people. Um, but that begins to neglect this idea that the other stuff is important as well. And then when people see that, they also create this stigma and this idea that this other stuff is not important as well. So there needs to be a cultural shift in, both within medicine and within the mental health professions of like, hey, we need to promote this stuff because it is just as effective. And we need to get that education out there for the other people, because the patient has these stigma and these expectations of, hey, I want to get better fast. Drugs get people better fast, so therefore I want drugs. I want drugs to fix what I have going on because this other stuff I've never heard of. I don't think that it's successful. And then there's the stigma around therapy still being a weakness of people, especially in men. And these are barriers as well. Like we have barriers for costs. We have barriers for taking time off of work. Whereas medication, there's no barrier, if your insurance covers it, right? You just take the pill, even though 50% of people do not take their medication. So it's just this very negative, redundant product that we have and that we're pushing out there from the mental health care, that's being funded, it's being taught, and the society has accepted it due to, the things that are being pushed. So, some examples of successful, is the collaborative care model. There's also the assertive community treatment that we talked about earlier. So, the collaborative care model is where they take in the biological, through the, primary care provider and behavioral health care manager, often a nurse or a licensed counselor, and then a psychiatric consultant from a team, to manage the care of the patients, right? So it's that big team collaborative effort, and organizations like the American Psychiatric Association, is now considered, the best evidence-based best practice. Is this collaborative care is now the gold standard from the American Psychiatric Association, um, and yet we're still not able to manifest that into the way we treat people. And then we have the assertive community treatment, which we talked about. And this is that delivery model usually run by community healthcare centers targeting individuals with serious mental illness who are at high risk for hospitalizations and homelessness. And it's a multidisciplinary, typically includes psychiatrists, nurses, social workers, vocational specialists, and peer specialists. And it delivers this intensive outreach, going to patients' home, community settings to provide care. And studies have found that it's 37% greater reduction in homelessness, which we already touched upon. And then we have the holistic veterans programs. Department of Veterans Affairs is an integrated system as pilots some of the most holistic and healthcare programs. For instance, the VA medical centers have a primary care mental health integration, which is very similar to the collaborative care and whole health initiatives that incorporate not just conventional mental health care, but also peer support, mindfulness classes, exercise programs, even yoga or acupuncture for PTSD, tackling both biological, mind, body, and social well-being. And they also have extensively use the peer specialist veterans with lived experiences. Through my research and interviews with veterans, one of the biggest stigmas that they found therapy not to be effective is because the therapist doesn't have that shared experience. So trying to find more things of the shared experience can be increasingly more effective for them to continue on with their therapeutic approach. So what are some recommendations to push this model? Again, we have that interdisciplinary training and workforce development. Like, what are we focusing on? Trying to collaborate, create these training models like a 4-year psychiatric and / psychology integrated residency. And then again, payment reform and parity enforcement, right? Financial incentives must align with BPS care. So we need to drastically shift that model. Wider adoption of this collaborative care billing codes in Medicaid, Medicare, and commercial insurance. If they're not being reimbursed, they're not going to be incentivized to do it. So we want to make sure that we can get that done. And then trying to have this integrated care expansion. The concept of behavioral health homes or certified community behavioral health clinics should be further supported, as these have been explicitly require like an integration of physical, mental, and social care, where integration within one organization is impossible. So building strong networks and communication channels between mental health providers, primary care, and social service agencies can be a vital way to impact them, and maybe some type of virtual integration for that. And then addressing the social determinants through partnerships, right? Again, this is a lot of it is just trying to create these partnerships, create this incentive-based structure to help build these collaborative care units, and support funding go into that as well. Adequate funding is a perennial issue. Like, where are the funds going? What are we actually trying to put money into? And a lot of it is pharmacological intervention, even though most of the SSRIs that are out on the market, the latest innovation of them was in 2001. So they're not even innovating within those own drug paradigms, even with the new research coming out of optogenetics and things along those lines to show that there are specific regions that maybe we should target to create better drugs for. But if they can't get patent, then they're not going to put the money and effort into it. So there's also the outcome measures and accountability, right? One of the pushbacks on the biopsychosocial is that it's not as definitive outcome wise as the biomedical care, right? Their outcomes are broader and more long term, where the biomedical is more concise and more short term. So to drive this adoption, we need to include more holistic outcome measures in their quality metrics. So track not just reduction in depression scores, but also measure functioning. Are they functioning within their community, within their society? Are they satisfied with the help that they're getting? And are they more recover oriented outcomes, right? Programs in England track recovery rates, percentages of patients moving from clinical to non-clinical range. US systems could similarly track the same things and reward providers who achieve the best results, right? Incentivize the results. And then just Cultural change, public awareness, efforts to educate the public about the nature of mental health can also support the shift. So those are the big components that we're trying to push with this, and that can make a difference in the U.S. healthcare system. And globally, there's been a lot of push for this integration, and places like the UK, Canada, the Norwegian states, they've all implemented Norwegian countries. They've all implemented this strategy very, very successfully. Um, Countries with US or universal healthcare tend to have fewer financial barriers for those patients to access multimodal care in their national policies. Like I said, Australia, the Nordics, UK, Canada aim for comprehensive service coverage, right? They're explicitly aiming for that service. And the US has made progress with the Affordable Care Act and insurance parity, mandating mental health coverage, but gaps still remain for this psychological and social services component. And then many other high income countries have national mental health strategies that prioritize community care, integration, and social support. The US doesn't have a single national system, but rather a mix of federal programs and state systems. So that's another one of the issues that we have compared to the countries that are pulling this off successfully. And then some countries have innovated unique cultural specific practices. Finland's open dialogue or Zimbabwe's friendship bent, these expand that psychosocial model. The US can learn from these and adopt. An adoption could be something that could be paramount. Like the open dialogues one for Finland emphasizes on family inclusion, and minimal meds could be applied more in the US, but the challenge is it's pushing back on the status quo of individual focused care and quick pharmacotherapy. Um, and then within the idea of like low income countries highlight the importance of community empowerment and task sharing. The US, despite being high resources, actually faces provider shortages, especially in rural areas, and could benefit from similar approaches such as training and utilizing peer support specialists or community health workers to provide outreach and basic psychosocial support. So this model offers a comprehensive framework for understanding and treating mental health disorders, but you can see the powerfulness of it, and but you can also see why we haven't adopted it yet. Um, and it's very effective care. Like the idea that effective care is one component of it instead of the multidimensional one. Um, when you understand the research, when you not even if you understand but you just understand human beings in general, right? It's ridiculous to assume that we should focus on one instead of having the multidimensional components. So research evidence and clinical experience both indicate that combining these interventions leads to better patient outcomes than focusing on one domain by itself. And the biopsychosocial component model is widely espoused in principle, but yet it's still not fully implemented, and it remains a huge work in progress due to reimbursement structures, fragmented care delivery, and training biases. Um, but we have seen some pushes and some improvements in that. So, in the end, right, the biopsychosocial model is not a rigid formula, but a guiding philosophy. It reminds us that people are complex in nature, and that treating mental illness effectively means treating people um, in context, not just the disease, right? The model calls for empathy and open mindedness, a willingness to look beyond symptoms and diagnosis to understand each individual's life story, strengths, and challenges. By breaking down these artificial boundaries between mind and body and between medicine and society, this model approaches alignment through medical practice with human reality. The task ahead is to continue transforming this understanding through research, through podcasts, through people having the voice to put this model out there and maybe make changes in funding and the trajectory of academia and education. and we can start to focus on creating these healing pathways that addresses the whole person and not a collection of different parts. That is the promise and the imperative of the biopsychosocial model in mental health care. And that's why it's so important to talk about it and to understand it and to convey that message, that we need to look at all these things instead of just the singular, especially the biological component, and continue to reduce the amount of overprescription and try to help these people in ways that are actually meaningful and beneficial, that we can see the outcomes and we can see the improvements, and create better qualities of life for everyone that is struggling, as mental health crisis continues to get escalated more and more. We tend to see things not going in the right direction. I think this model allows us to approach it in a more unified, collaborative method that will allow it to start to go in the right direction. So I hope you guys express and voice this model as much as possible, and continue to look at the research, continue to look at the places that are doing this stuff, and support those places with everything that you can. So I hope you guys enjoyed the episode, and I'll get you on the next one.